Everyone, and welcome back to Australian Neonatal Lectures. My name is Tuba. I'm one of the neonatologists in Brisbane at Mater Mothers Hospital and also a researcher in Melbourne, and I will be hosting today's session. Thanks for joining us. We would like to begin by acknowledging the traditional custodians of the land on which we are each meeting today and pay our respect to elders past and present. A few housekeeping points before we start. Please keep your microphones muted and post any questions, any difficult question to our speaker comments in the chat during the presentation. We will try to address as many as possible in the end of the talk. And now I think it's my great pleasure to introduce you today's speaker, Associate Professor Koert de Waal. Actually, Koert needs hardly an introduction. He is very well known to you as one of the main hosts in Australian neonatal lectures. Koert works as a neonatal consultant in John Hunter Children's Hospital in Newcastle, and he is widely recognized and world known for his expertise in neonatal hemodynamics and for his passion for bedside ultrasound. So Koert today is going to talk us about intraventricular hemorrhage. As you all know, IVH is a critically important topic in our units. We daily deal with IVH. We try to do our best to prevent it, but despite all the advances in neonatal care and neuroprotection bundles, IVH remains as a major contributor to the mortality and also poor neurodevelopmental outcomes for our preterm population. So today, Koert is going to talk us about IVH and underlying pathophysiology of IVH and also discuss potential strategies for prevention. Thanks, Koert, for accepting this invitation. We are so excited to hear this talk. Now over to you.
Thanks, Tuba, and thanks for this introduction. And indeed, can we prevent? I think that's probably the main question we always have. IVH in our preterm infants. And I think when we start about talking about a disease, we need to know what it is or a complication. And these are two slides, pathology slides of the typical sort of IVH we as neonatologists encounter. And when we look at IVH as sort of over time, particularly in preterm infants, we start to realize that almost all of them start in the germinal matrix. And there is a good reason for that. If you look at the germinal matrix from a fetal sort of developmental perspective, you can see from the left to the right of your image where the germinal matrix is in the top one in sort of deep purple, and the bottom one in brown. And then you can see that development over time, that it is actually really big before it starts to involute and get much smaller. And the reason for that is that the germinal matrix is carrying neural precursor cells. So the in sort of original primitive preplate subdivides, and then it creates those layers in the brain which we are familiar with, certainly later in development. And these layers and these neural precursor cells, they have to migrate, and they have a developing gradient going from sort of the lower end, the germinal zone, into the white matter, into sort of the further matters, going upwards. And of course, they need a guide to go somewhere. And further research sort of showed that this guide is usually neuronal microvessels. This is a beautiful picture of a frontal lobe of a very young gestational age, and then sort of zoomed into it, you can see those neuronal microvessels. And I just remember my very first student project is that we had to cut out a little bit and put it upside down back into a growing plate, and indeed the cells could still find its way along the microvessels, even though it was sort of given the wrong direction. The germinal matrix, and thinking about these vessels, there's an old saying in the Netherlands that all roads lead to Rome, and I think of the germinal matrix in the developing brain as being Rome. So of all the vessels early on are connected to this central point, which is the germinal matrix. This is a really nice anatomical study showing the vessel density area per sort of, structure there is. And of course, the germinal matrix is much higher vessel density area when compared to, for instance, the gray matter and the white matter. But not only is there a higher blood vessel density in the germinal matrix, they're also of a different structure. And that's probably equally important of why that has a higher risk of bleeding. So here is again a very nice anatomical study looking at the germinal matrix in the middle, and they compared it against vessels in the white matter. And what you can see is that the fibronectin in red is much less dense in the vessels in the germinal matrix. But maybe even more importantly, you need to have this laminin cover that makes the vessels elastic and bendable and stretchable. And that laminin cover, as you can see, is very well structured in the vessels in the white matter, but not very well, even if at all, structured in the vessels in the germinal matrix. So these combined effects of having a lot of vessels and not being very stretchy can lead to fissures. This is a microscopic sort of view of the germinal matrix epithelium. And on the left, you see a magnification with an electron microscope, and you can actually see the fissure. And when they zoom into that fissure, even to 1800 times, you can see the body trying to, stop the bleed around that fissure by making fibrin bundles, red cells, and of course plate cells. Platelets will be captured into that as well. So when you develop your IVH, intraventricular hemorrhage, I think in not all, but in most cases, we see it will start in the germinal matrix. And from the germinal matrix, blood sort of seeps into the ventriculi, which we call an intraventricular hemorrhage. And then it can sort of do a couple of things. And one of them is actually obstruct the venous return, and we'll get back to this, and develop this periventricular hemorrhagic infarction. And also mechanically, in most cases, it can obstruct the flow, sort of going downwards, so you get this post-hemorrhagic ventricular dilatation. The old classification we had, or the very first classification that happened, was by Papil in 1978. These are pictures from his original sort of study where he started to grade this intraventricular hemorrhages in preterm infants into 1 to 4 with or without ventricular dilatation. But of course, CT is not the most optimal sort of tool to image the brain, certainly not in the newborn. So actually very soon, in that sort of same age, it was the development of ultrasound. And this is one of the earliest pictures I could find. And if you look at that picture on the left, you got to look, and that's where I put the arrow there. That's where the little baby's nose and eyes are. And this sort of contraption was put on his head to look to the pictures which were generated, as you can see on the right. And one of my very first mentors, Baarsma, he told me, these were the kind of pictures we sometimes made decisions on in the very early stages of neonatology. Now, luckily, there's been a lot of development in ultrasound and ultrasound technology. So now we have this is probably the most commonly used sort of gradation of intraventricular hemorrhage, with more sort of advanced ultrasound technology, going from grade 1, where it is a germinal matrix hemorrhage, and how much sort of blood goes around it, whether it occupies up to 50% or over 50% of the ventricular area, and whether then it extends into the parenchyma as a periventricular venous hemorrhagic infarction. We have worldwide, I guess, most systems will have a classification where there is benchmarking and everybody reports on a yearly or some quarterly basis, and you're going to have these numbers. And these are numbers from the ANZNN from 2017 to 2023. And they reported in grades 1 and 2, and then what's called severe IVH, which is grade 3 and 4. And these graphs, I think, are the same all over the world. The younger you are, the more likely you will have an intraventricular hemorrhage, and also the more severe ones tend to be appearing and happening in the more younger gestation age infants. There is a very close relationship between intraventricular hemorrhage and its grade and the associated outcomes in neurodevelopment. I'm highlighting one of the studies. This is a beautiful study from the Melbourne group in 2020, where they have these sequential follow-up of groups or cohorts of preterm infants up until, I think now, almost young adulthood from the first cohort. And that tells us a lot of what's happening over time. On the right, you see the relationship between IVA grades and IQ, and more than two standard deviations below average. And you can see this rise happening from IVAs 3 and 4. And on the right, you see the relationship with cerebral palsy. And there, the rise or the difference between 3 and 4 is actually really substantial. And I think there's a good reason for that. One of the reasons might be explained that actually most IVAs, that's what we call it, intraventricular grade 4, are actually IVAs grade 1, 2, or 3 with then a periventricular hemorrhagic infarction. And that infarction is sort of the pathophysiology, the timeline. It starts with venous obstruction. You get this pooling pressure of blood, which wants to go a certain direction, usually downwards into the central brain. And that pressure might then lead to vessel ischemia or even rupture. So you get this infarction with or without a local hemorrhage. This location of these periventricular hemorrhagic infarction, these are more venous than they are arterial, is very well anatomically studied here by Dudink from Govaerts and his group in Rotterdam, where he followed and measured and looked at all these veins on an ultrasound sort of technology. It's a beautiful way with looking at which part of which vein will have the obstruction. Therefore, that's where you can then expect that periventricular hemorrhagic infarction. Is this important? Is this, helpful? I really think it's very helpful. I think we need to grade IVH4 into several other portions. It's not just grade 4. You need to then give it a severity score, but because there is a huge difference. And one of the grading which is proposed is by Basson, the periventricular hemorrhagic infarction severity score. It's a bit of a mouthful, but it basically looks whether it's unilateral, bilateral, whether there is a midline shift or not, and how many territories are affected. And particularly that last one, I think, is really important because that's evident from many studies which look at, some damage in the brain and a neurodevelopmental impairment. And generally, the more areas that are involved, the more likely you have the risk of neurodevelopmental impairment. And as you can see here, you can have an IVH grade 4 at a very low score, which then is more associated with outcomes which we usually give at much lower grades of IVH. However, if there's more areas and more things involved, certainly when the score is 2 or higher, then there's a very high risk of having neurodevelopmental impairment and other morbidity. The relationship between all these gradations and outcomes, I think, is really important, but some of the things we see are changing where it seems that we're seeing more or different sort of pathology happening. And one of the things we do have to bear in mind is the advances in ultrasound. Here I took a scan in a baby with sort of exactly the same baby at exactly the same time with a probe which from a previous generation, comparing it to the last generation ultrasound probes. Way more piezoelectric elements, way more detail that can be obtained to sometimes almost, MRI kind of quality. These advances is mostly, artifact production algorithms, way higher frame rates. This technology, if you think of your phone from 1990, which it wasn't even there, but say 10 years ago and now, there is huge advances, which we also see in ultrasound. And one of these things they have brought us, which I thought was really is an algorithm to look at that low flow in that venous system. In that venous system, one of them, so the cortical microvessels, they're connected separately, but there is a system which connects the germinal matrix through the collective vein with the medullary microvessels, which I think is very important in the development of IVHs. Here's a sagittal view looking at that cortical microvessels, that little brush on the top, and then those medullary microvessels. Interestingly, those medullary microvessels, the younger you are, and particularly 23 weeks and below, they interestingly haven't decided whether they're an artery or a vein, and they can still differentiate in that period of time. This is then an example of a baby with a big bleed, and you can now visualize the dense terminal vein with most likely increased venous pressure. Because if you then follow them over time, you have this periventricular hemorrhagic infarction with an existing bleed, and on the other side, you can now see this dense collector vein. That must be a venous obstruction. And in this particular case, the next day, there was a fresh new bleed in that location. So this tells us something about how we can maybe better and deeper and more detailed studies the development of these IVHs. So intraventricular hemorrhage, particularly the grading, I've had to summarize it. I think the classical gradation shift systems are certainly associated with neurodevelopmental outcome. Personally, I find the grading between IVH grade 2 and 3 can sometimes be subjective and tricky, but certainly IVH grade 4 needs more detail to be helpful in predicting a more detailed outcome. And I recommend using one of the periventricular hemorrhagic infarction severity scores. So I talked about the risk factors for the pathogenesis of IVH. Fragile capillary network of the germinal matrix, preterm birth, those were, actually the main ones which lead to it. But there's a bit more to it. We now understand that fluctuations in cerebral blood flow, with or without impaired cerebral autoregulation, also plays a very important role in the development of IVH. And there is certainly quite a lot of work done in immature coagulation, and it's difficult for sure. And it seems to be more of a matter in the term baby who developed an IVH than in the preterm baby. So fluctuations in cerebral blood flow. Here's a picture which I sort of gradually put together looking at fetal cerebral blood flow and where would those fluctuations then come from. Now, of course, the pulsatility, which you can see on the right of the screen, of mom's flow and mom's pressure will be managed and dampened within the placenta. So if you actually look at an umbilical vein Doppler, then you actually won't see much sort of changes happening there. I think that's really important. Once you then get to the ductus venosus, then you see pulsatility coming back again, but that pulsatility is actually the fetal heart creating those little changes. But if we think about the newborn, fluctuations in cerebral blood flow, birth itself, what we do immediately after resuscitations, we cannulate, we do intubate, we give surfactant. I'm sort of more surprised that not all babies have an IVH because there is so many fluctuations in cerebral blood flow. I guess one of the reasons why not all babies have IVH because they do have cerebral autoregulation. The brain wants to have a constant cerebral blood flow, and it can do this over a variety of cerebral perfusion pressure, which is shown here in the horizontal axis. So if there is, less and less cerebral perfusion pressure, what will happen in this autoregulation, the vessel diameter goes up, just to maintain the same amount of cerebral blood flow. However, though, there is a lower limit of autoregulation where they can't keep up, and then, of course, cerebral blood flow will go down. Importantly, and we could get back to that at the end, there's also an upper limit of autoregulation where the vessel diameter increases and there is too much cerebral blood flow. With more and more studies over time, this is a beautiful review from Surak. I think this summarizes really the cerebral autoregulation. What we think about it is that window of autoregulation with the lower limit of autoregulations and the upper limit, and that window of autoregulation is probably much smaller in the preterm infant when you compare it, for instance, with a term infant or with a 1-year-old. Important to understand also that cerebral perfusion pressure is blood pressure minus intracranial pressure. What we know about cerebral autoregulation has, particularly in the clinical field, has come from looking to the relationship between blood pressure and cerebral blood flow. And for that, you will need continuous arterial blood pressure measurements and some sort of measurement of cerebral blood flow. And most commonly used is NIRS, and others which is used is transcranial. And there are some laser Doppler and some other studies as well. And basically what you're looking at, if there is a high correlation, then there is impaired autoregulation. And when there's no correlation, there usually is normal working autoregulation. I'll show you an example, which I think is really great to explain that. This is from Flora Wong and her group in Melbourne, that if you look at the mean arterial blood pressure here in red, and then the proxy of cerebral blood flow, then there is, when that blood pressure starts to fluctuate during a care, then the cerebral blood flow is actually nice, not completely stable, but nice and stable. So this is intact autoregulation, poor correlation between the two. But now look at this example on the right, where blood pressure fluctuates, goes up and down, and with it, the cerebral blood flow goes up and down. So this is an example of impaired autoregulation with very good correlation between the blood pressure and cerebral blood flow. So with this sort of in mind, and by consensus, the groups in the world who worked on this, which is this is one of them from the group in Utrecht in the Netherlands, they just measured the percentage of time in which a preterm infant would have impaired cerebral autoregulation. There's a cut point, they used 0.5. You could argue if it should be higher or lower, but this is what they went with. And this example shows, wow, okay, so it's not just cerebral autoregulation or impairment of it. This is in the 24 to 36 hours period before the development of the IVH. There were certainly more babies who developed an IVH who had more time with impaired cerebral autoregulation, but it was actually quite large overlap. So if you summarize, this was just one example, but if you summarize all the data which there is on cerebral autoregulation in clinical studies, I found out that it's actually not a continuous phenomenon. You can have time minutes on and time minutes off, and that varies during the day. It certainly improves with increasing gestational age, but also importantly, I think impaired autoregulation alone does not always lead to an IVH. It needs to combine with something, either too much cerebral blood flow fluctuation, or something they found which they call the ischemia reperfusion cycle. The ischemia reperfusion cycle is where there is a period of low cerebral blood flow for whatever reason, which is then followed by a period of increased cerebral blood flow. This is an elegant study for Sarah Nori from California, which then showed that after that reperfusion phase, so you saw the top line, which is all babies who didn't develop an IVH, which had a very stable cerebral blood flow. But the babies who did develop an IVH had a period of ischemia, low blood flow, then it went up, the reperfusion, and then the actual hemorrhage occurred where the blood flow went down again. And of course, our colleague Martin Klupko from North Shore in Sydney had similar findings, but instead of measuring with NIRS, he measured with ultrasound, and he used the venous return from the brain, the superior vena cava flow. And these cases was his first sort of series, and this has been then confirmed in larger studies, where there was this beautiful, higher blood flow before, it goes down, and by the time it sort of comes back up at the end of the reperfusion, you had your highest risk of developing an IVH.
Evidentemente, no es un buen amigo.
So the title of this talk is, well, can we prevent that? So I think if we know now bits, not everything, but certain bits about the pathophysiology. Can we prevent that then? Can we prevent cerebral blood flow fluctuations in the early phase? So preventing that ischemia phase, and I think we can. There's lots of antenatal interventions, what I'm going to talk about in delivery of care. But then can we prevent the ischemia reperfusion cycle? Should we treat and prevent low blood pressure, low blood flow, and how should we do that? So antenatal interventions we know of, which are known to prevent IVH or reduce the risk of IVH, is one, maternal transport to a regional neonatal center. And I can't emphasize enough on how important that has been. Of course, prenatal glucosteroids and prevention of prolonged labor. So the maternal transport to a center, this is NICA's data 2015, because I remember when I came here, I think over 15% were born in one of the smaller hospitals and then came to us. And they were certainly known to have a higher death rate, so a lower survival. And when you looked at that data, you could also see that the outborn were more at risk of developing severe IVH than the ones who were inborn. And we have a much lower percentage of babies who are born now in the tertiary centers. It comes at a cost. That means a lot of women go to your center, have to stay there in threatened preterm labor, then they don't deliver. So they do occupy a lot of space and resources in the centers, but then at least you get a better outcome if preterm delivery occurs. Antenatal steroids, this is one of the ANZ data. We are really good. I think everybody is really good. Whenever we think of preterm birth, give some steroids to mom and think about it. What is the next step? This was interesting though. This is a study which looked at the time between receiving antenatal steroids, your first dose, and then birth in hours, and the relationship in a very large cohort, 4,500 low birth weight infants, in hospital mortality and severe IVH. And there is a gradient between, giving your steroids. And so having more time, which makes sense, isn't it, to have the steroids on board will improve your outcome. And as you can see from this one, it seems to be like 24 hours is certainly the ideal scenario. This was interesting. This is a German study, and I only found like 3 of these studies, but this was the biggest of studies. It was quite a large cohort, I think over like 10,000 or 15,000 high-risk deliveries. And sure, retrospective. They looked at, okay, if there is, let's do the risk of IVH, planned cesarean section is 1. And then we look at what improves outcomes. So you get the expected thing, antenatal steroids, female gestational age, bigger, all improves outcome. But then what increases your risk was an emergency cesarean section and vaginal delivery. So this, I think, is interesting, and is maybe something healthcare regions might have to explore for themselves if that kind of risk is also occurring in their own region, and if this is something you can think about. There is absolutely lots of scenarios we can't avoid an emergency cesarean section of vaginal delivery, but maybe there's something to think about. This is what we certainly know, had the original study showing that if you do delayed cord clamping, particularly you do delayed cord clamping after ventilation onset, then you can see the changes in systemic blood pressure on the top, pulmonary blood flow in the middle, and most importantly, carotid artery blood flow in the bottom. And if you do that after ventilation is started and then you clamp the cord, you get much less cerebral blood flow changes, or immediate cerebral blood flow changes. So this led to all the studies over time, and the biggest one, the APTS trial at the end, which looked at delayed cord clamping. And this is then the summary of all the trials. Delayed cord clamping is an effective, available, simple, cost-free perinatal intervention to reduce IVH. So this should be standard of care in every center all around the world. How to get there? They say the goal would be to get 80% delayed cord clamping in all your deliveries. This is ANZ data, looking at less than 32 weeks. And it took us, this is a 4-year period where we started, the educational program and try to get it up. And we're pretty good now, around 80%. And the tip I would give here is that, in whatever scenario, in whatever room you come into and you're there as the neonatologist, talk directly to your obstetrician and say that, no, we're going to do delayed cord clamp. Don't worry. I will tell you when to clamp the cord. I will tell you when to bail out. I think that helped, to you taking the responsibility of that cord management at sort of complex deliveries at very early gestation. There's alternative ways. Anup Kateria from San Diego, he's a trialist and is very focused on anything that happened during resuscitation. And he was the first big delayed umbilical cord clamping versus umbilical cord milking. Now, we had to stop this trial when only 1/3 of the babies were enrolled, because delayed cord milking actually increased quite significantly the risk of severe IVH. And I guess you can sort of expect it, because you put large boluses of volume into a baby, which is already born, and then you get significant cerebral blood flow fluctuations. So there was some sort of trials also in Melbourne looking at, but you could do it a specific way and be more precise about it, but that was not the most practical one. So this one was stopped. But then this, you got to give credit where credit. Anup went like, no, I'm not going to get, no, it still works, but let's just do it in the bigger babies who have more mature germinal matrix. And another 1,000 babies enrolled. And here he found no difference in clinical important outcomes. So now also in the AAP, it says cord milking might be an alternative to immediate cord clamping in infants over 28 weeks. Delivery room intubation has long been discussed for various reasons, but maybe not as much for IVH, I think, as being, should this be the first line, and what will be the cut point? And certainly for myself, I've been trained in Amsterdam that 28 weeks, you would do delivery room intubation. That was just, that's what you would do. And now over time, we do less and less, and only in the more smaller babies we would do it. This is a beautiful study from the US looking backwards at, a very large cohort, 44,000 babies, 7.7% with severe IVH. And then this regression analysis looking at contributive factors for severe IVH. Some of them are very logical. The lack of antenatal steroids, no cesarean delivery came here as well, but it was a minor course. But delivery room intubation was a contributing factor to severe IVH, in particular in the larger gestational age groups. And I guess because over time we've learned that, these babies probably don't need that. And you can wait and then maybe just do surfactant and CPAP. And I think that's important. Others have tried to do something more during resuscitation. I'm going to show you this one, which was another trial which looked at sustained inflations, which led to an increase in IVH. But fair is fair only in the IVH grade 1 and 2, not necessarily in the severe IVHs. But once you come out of the delivery room and you want to then support, then if you look at this is a Japanese sort of analysis, which looks at different forms and different studies. The bowls will tell you the size of the bowls, how many trials were done, and the black line says how many comparisons with different sort of structures were done. This is an old one now, 2016. I haven't seen an update, but it would be great to see an update on this one. But at that time, the ranking was Lisa was the best of reducing IVH versus Ensure versus NIPPV versus mechanical ventilation and CPAP. I was a little bit surprised by that finding, particularly the difference between Lisa and Ensure. But for both, you still need to access or visualize the neonatal airway. And intubation attempts and cerebral blood flow fluctuations are well known, but I can imagine just putting the McGill in, if you look at those particular studies, that already gives significant changes in blood pressure and saturation. We have tried to dampen those fluctuations by giving pre-medications, and although it certainly makes the intubation attempt easier and shorter, the effects of the medication either before start or after the intubation are still prevalent to leading to cerebral blood flow changes, either through hypotension or hypertension. So we come to that next phase of, prevention of IVH, so antenatal care, delivery room care. We have certainly some sort of good suggestions of what helps and what might help, or maybe what we should do. This part is a little bit harder. Can we treat or prevent the ischemia reperfusion cycle? Talk about treatment of low blood pressure, treatment of low blood flow, but probably what we learned over time is probably easier to try and prevent low blood pressure and low blood flow and blood pressure fluctuations. Treatment of low blood pressure. I think there's decades of studies looking at this. First was large cohort studies looking at, who is actually most at risk of severe IVH or PVL in these particular studies. And you found that the treated babies had higher risk of severe IVH or PVL. You go like, well, that's logical because they were so low and they needed to be treated. But interestingly, the difference between, untreated, isolated, or isolated treated, so having just a low number versus being symptomatic and treated, was actually a quite difference. And then came the randomized trials. There have not been many, they've not been large. 2016, 2019, 2021, and 2025. And one of the things which maybe led to and then none of these had particular differences in outcome IVH, is that they followed this guideline, the stepwise guideline. First some volume, then some dopamine, then you add medication, and then you add adrenaline, you add hydrocortisone in different sort of phases. And this one-way approach, I don't think is suitable for hemodynamic management. Another thing they found out, and that was actually quite interesting, that the percentage time with impaired cerebral autoregulated increased with increasing doses of dopamine, which was the most commonest first-line drug to treat low blood pressure in preterm infants. There have been few studies who will tell you how best to treat low blood flow. David Osborne was his first, but I'm going to highlight this one from Maya Bravo, as she's from Madrid, which indeed show a lower risk of severe IVH if you treat low blood flow, and she took SVC flow with dobutamine when compared to placebo. This whole treatment, let's say assessment and then treatment of blood pressure with a protocolized approach with escalating doses, usually with a long exposure time and a high use of dopamine, is something which is slowly disappearing in centers which have embraced individualized targeted hemodynamic treatments, and particularly bedside ultrasound for the assessment of cardiovascular dysfunction. This individual targeted approach in 3 or 4 large cohort studies has shown that it can be done with lower doses, shorter exposure time to those medications, much less use of dopamine and alternatives we use, and more use of inotropes versus vasopressors. And in all these cohorts, that has led to reduced mobility and reduced mortality in those particular centers. Instead of treatment, maybe some words about prevention of low blood flow and low blood pressure. We always have seen this sort of picture as the most commonest reason of why low systemic blood flow and pressure occurred. You go from this low intrauterine vascular resistance directly to a higher extrauterine vascular resistance. If you put that on an immature or sick myocardium, then you have shunts of blood out of the systemic circulation, which was then the PDA, and you add positive interthoracic pressure ventilation. That leads to a higher risk of low systemic blood pressure and blood flow. And in, I would say about 15 years ago, that incidence in babies less than 28 weeks of low systemic blood flow and or low blood pressure was 1 in 3. And I think by not doing that anymore, by preventing it, by adding delayed cord clamping, improved antenatal care, and not straight jumping towards positive intrathoracic pressure, but either LISA or Ensure and then CPAP, has led that to this prevalence to significantly drop into now sort of 1 in 10. We talked a lot about the lower limit of autoregulation, but I think we need to put some words in on the upper limit of autoregulation as well. There's very few data out there, but this is from Karen Rama, that's from the Utrecht group again. Not in very young babies, it's quite old babies, 34 weeks and up. But I was surprised by the upper limit of autoregulation with a mean arterial pressure, which is not even too extremely high. We can see that in scenarios. We see that in cases due to various things we do to them. This beautiful study looked at hemodynamic fluctuations according to events, and even a diaper change can give significant changes in cerebral blood flow, either up and down. So they presented as the delta, the change in blood flows. ET repositioning, suctioning, complex events, those are all very impactful scenarios to the preterm infant. Here's another example from an Austrian study which just looked at arterial blood sampling and the changes in cerebral blood flow, usually downwards, the delta was downwards, and then particularly during flushing, that it go upwards again. Just simple things. And I think of the IVH, and particularly in this scenario, there are risks of IVH. And then you have that whole thing aligned together. Import autoregulation, ischemia, reperfusion, routine events, it just aligns the Swiss cheese into actually developing your IVH. I'm going to summarize with a couple of slides and come to sort of maybe some other things which we can then do. In the prevention of IVH, I've talked about, maternal transport to a regional neonatal center, very good evidence. If possible, planned cesareans, reasonable evidence, particularly after antenatal steroids. Umbilical cord clamping after onset of ventilation or delayed cord clamping, avoid cord milking, avoid routine delivery room intubation, avoid sustained inflations or high tidal volumes. There were some other studies, and the earliest, least invasive effective administration. But there's a little bit less evidence and more just educational typing, thinking about physiology. How to treat hypertension, not with dopamine, treat low blood flow with dobutamine, small study, but individualized targeted hemodynamic treatments is one of those suggestions and ideas which doesn't lend itself for a randomized controlled trial to see which one is better. It's just evolving of medical care and understanding with deeper insight into the pathophysiology. And I guess that same applies to those neonatal care bundles, the QI projects. But they don't take just one thing. They take a lot of things together. And this care bundle over time has then been looked at how well is people adhering to it. I think that's one important thing. And how well can we then get to something which is better over time. And there's different things in different care bundles, but one of the things I want to highlight, this is an initiative from an Australian group where they want to look at if midline head positioning, because it's been, and this is a great article where it describes, this actually has been used more and more, but do we even have evidence? Does it work? I know it's in the care bundles, but where does it come from? Maybe we should actually do a trial. So this is something, if you're interested, type in the PIN trial, IVH, and you'll find information to contact this group. If nothing changes, I think that's my statement. We really need to try to limit unnecessary routine interventions that can induce cerebral blood flow fluctuations, particularly very early after birth. Think about routine suctioning, routine cares, gastric aspirants, bloodletting. How much do we really need? And, the use of sedation. I'm going to stop here, and then we have some time for discussions.
Thanks, Kurt. This was exceptionally insightful, amazing presentation. So you beautifully summarize us the complicated pathophysiology behind IVH, all these interactions between systemic blood flow, cerebral autoregulation, how immature are the preterm brains, and you focus on multiple interventions, multiple strategies. We already have some questions. Celia is asking a great question and is wondering whether we exactly know how the antenatal corticosteroids prevent the IVH at cellular level. So is there an increase in the germinal matrix, vessel fibronectin, or laminin covered structures?
It's a great question. There's some animal data looking into this, but I always think about it I'm a clinician more than I've never done animal studies. I love reading them, but if it works within 6 to 12 hours, you almost can't change directly the structure, but could it sort of arrange the laminins, or could it something? I don't know. It's all yes, but maybe. My input is, and what I think about it is probably more on a regulatory level. So your vessels and the tendency to be able to constrict or dilate is regulated by local scenarios, whether it's nitric or histamine or oxygen, versus directly working on the structure of the vessel. So, but yeah, interesting material there.
Yeah, thank you. So when our participants are thinking about their question, maybe I can go with one of mine. So as you mentioned, and as we know, the smallest babies, the most immature ones, are the highest risk for having an IVH. So for all the preventive measures that you talk today, do you think they apply to all gestational ages, or these 22, 23 weekers we need different strategies?
No, that's really good. Well, yes, I think so. Almost everything we mentioned here, maybe not the treatment of blood pressure, that might be the hardest one to answer in this particular context, but you still want to prevent cerebral blood flow fluctuations. You still want to have that baby born in the best conditions. I guess when you come to 22 weeks, that a strategy of getting zero IVH will be very, very difficult, because they're fragile, and even in their fragile state, with maybe just some movements, you can have these kind of things happening. But I still think there's the possibility to reduce it in every gestational age group.
Thanks, Kurt. You can just post your questions in the chat, or you can just unmute yourselves and ask your questions, or
there's
just
lots of questions there. Yeah. You see all the questions. You want me to go to the questions which are there?
Oh, yeah. Perfect. So, will giving sedation medication to a micropreemie with grade 1 IVH prevent further progression of IVH?
Sedation has a double action. I can imagine if you want to sedate a baby who cries a lot and fights a lot, but those are generally the bigger babies, so you might not need it there to prevent the cerebral blood flow fluctuations. In the smallest of babies, I'm not so sure. The risk of developing complications, which is hypotension, are quite high with sedation in the micropreemie. So the optimal sort of findings there, what we need to do, I still think is a challenge. Finding what is we know from the 28 weeker that a lower blood pressure, the baby looks good, the pH is good, his urine output, we're quite content. You're like, no, this is a number and we don't need to treat it. When you come to the micropreemie, that becomes increasingly difficult, because cerebral blood flow fluctuations is one thing, but you still need to have enough cerebral perfusion pressure, which we talked about. And the perfusion pressure is about your intrathoracic pressure, but particularly your diastolic pressure. And think about the micropreemie 400 grammer, and with a blood pressure of 33 over 15 or over 12, that there is much less sort of leeway to come to a diastolic pressure where there is no cerebral perfusion pressure to be made. And so I think the micropreemie brings extra challenges.
And Wininder is asking your experience at John Hunter with cord clamping after establishing ventilation.
Yeah, well, look, there were such big words about it, and because we did the time, wasn't it? It was 30 seconds, and now we go to 60 seconds. But when you look at your baby, you're standing there, and we did the APTS trial, and you clock them, and just waiting for it. Our obstetric team was wonderful. They went like, "Oh, you take it over, then. All right, we'll just I'll just wait here then." And you watch them breathe. You watch them taking their first breath and the second breath, and then and when they're relatively stable babies, because those are the ones which went into the trial, I think about 15 breaths was about 30 to 60 seconds anyway. So I think the 30 to 60 seconds overlaps with establishing ventilation. Now, if you have a baby who doesn't breathe at all, you got a bit of an issue, because should you then establish breathing with mechanical ventilation? And those are the trials, doing resuscitation on the cord. Interestingly, they started that with the bigger babies first, and there is now some trials going to the smaller babies. So I think we have to wait the results of what they sort of bring us, not only on outcomes, but also on their experiences of the logistics about it and how well that can be done.
Thanks, Kurt. I don't know, Somil, if you would like to unmute and ask your question, but it's a very detailed question. It's saying that thanks for bringing up the Bassan's classification for grade 4. As we all know that grade 4s are not the same. Another one, Apti classification. Perhaps we should all move towards to more objective scoring for IVH and their long-term correlation with the outcomes.
I remember an ANZ and then special interested group. I think there were 8 people there, and we had to decide how to classify and define. And the longest discussion was actually about grade 2 and 3. Oh no, I call this grade 2. I call this grade 3, and because it's rather subjective. I'm not sure if we can get much further into that aspect, grade 2 and grade 3. I am with you there that grade 4 needs more detail, and I think the Bassan score is so easy to use, so I would recommend that one. I wasn't aware that there's another one, so just make sure that you just classify unilateral, bilateral, and how many areas are involved, and because it's such a good relationship and a better relationship in giving parents the range of outcomes to be expected, which can be very different with an IVH grade 4 Bassan 0 versus an IVH grade 4 Bassan 3.
Thanks, Kurt. One controversial topic in our field is treating or not treating PDA. You didn't mention much about it in your talk, and it was one of my questions too, and I'm happy that I'm not the only one that is going to raise this question for you, few questions for you. One, do you treat preterm PDAs in your unit? And does ibuprofen that we treat for PDA can cause IVH? Would you check head ultrasound before giving treatments?
No, those are fair questions. So the whole IVA PDA sort of relationship came by talking about the pathophysiology of PDA. It might either give left to right. So, and here are 2 different hypotheses in the world. I'm raised by Nick Evans and Martin Kluko, which said actually no, it's left to right shunt. It's increased flow, which is associated with the reperfusion in the PDA-related abnormalities. And others say, oh, isn't it the steel which takes the blood flow away? And so that's already one thing which we haven't really concluded. And then people started, well, maybe not necessarily do prophylactic treatment, but the first treatment prophylactically was with indomethacin. And they found it was no significant difference in neurodevelopment impairment, but if you looked at it carefully, there was a lower grade severe IVH. And the trial didn't do an ultrasound before they gave the medication, but they gave the medication, in less than 12 hours. In a preterm population, less than 1,000 grams. So do you need to see if there was a PDA or not? Most of these babies will have a PDA anyway. And it went down severe IVH from 13% to 9%. So it was nice. It's like that's great. If that would help, you should just do that. But when you look further at the cohorts thereafter, which had implemented this strategy into practice, and there's a couple of cohorts, one with 4,000 patients, one with 2,000 patients, and they could not find it. Their rate of severe IVH was 13%, even with prophylactic intervention. So that's one sort of thing. Then now we had 3 trials looking at prophylactic, either ibuprofen, and just recently came out prophylactic paracetamol, which showed no significant difference. So I think I like to look at anything for everything, and to learn about what is the risk profile. A head ultrasound is so easy to do by a bedside clinician that you can have that information really quickly. So I tend to do it, but in our unit we would not use prophylactic treatment not even in a selected population like the really young ones or maybe the males or whatever you want to choose.
Thanks, Koert. And what level of evidence do we have for rapid sequence intubation in the late delivery rooms for 23-24 weekers?
I don't know. I have to look that up. Yeah, I would agree with you that the trials who looked at rapid sequence intubation, basically using pre-medications, are mostly outside the delivery room. That's already one. And they're mostly in bigger babies. Because you can imagine it's not that easy to study. You need to have somebody with a clock next to it who looks at all the little details and then gives you, and then you need to have a blood pressure measurement if you want that to include into your trial. So I think the question is relevant. It would be hard to study. Let's say that. I would expect if you want to look that up into the literature, you most likely will find animal studies and not clinical studies. But I'll be curious. I'm going to look it up later.
Thanks, Koert. I asked this question because in Edmonton, where I was there last year, it's a usual practice nowadays for extreme preterm babies to do rapid sequence intubation. The first preference is to do either a PIV or a umbilical line and then give the medication and then intubate. And meanwhile, we just do the non-invasive CPAP. So that's the usual practice over there. I was wondering if that's a practice anywhere else as well, and if there is some more evidence on that. But something to look for.
I know there are centers in Europe who do LISA, but then with half a dose of pre-medication. Now, if you talk to pharmacokinetics in the room, they go like, what? There's no such thing as half a dose. But that's on one end. But on the other end, when the pharmacokinetic people looked at morphine, fentanyl, etc., to particularly during transition where your liver metabolism hasn't transitioned yet, that some would respond really rapidly and had really high peak doses and really nice eliminations, and others, they could have that on the board for days. So I think it's not that easy to, again, like all babies will then benefit. I think some babies will benefit, and some of your babies will now be at risk of hypotension in the aftermath. So those are the balances you need to weigh out. And I guess this is one of those things where you can look at in a QI kind of matter. I wouldn't randomize this. I would look in a QI kind of matter. Did that practice change our severe IVH rates in these small little babies?
Thank you.
Thanks, for sharing your practice change with us. And Tom is asking, what is the timing of the majority of severe IVH in terms of days of life?
Yeah, there was a paper that came out, I think last year, which said, the IVH occur a little bit later. When you look deeper into that particular paper, you also found that, wait a minute, they just looked retrospectively at studies who reported on IVH, but their reporting on how many scans they did to detect it was actually quite minimal. There were very few studies who looked every day and can truly tell you about the timing of IVH. I think the only one who can sort of report on this is probably the Japanese, but they haven't, which is really a pity because they do scans every 6 hours. So they should be able to tell us. So we need to ask our Japanese colleagues if they have some data on this. I have seen late IVHs, absolutely. Everybody has. but I actually think a lot of that late timing is related to late looking.
Thanks, Koert. If there is no other burning question, I think we are going to end this session here.
Wait, Pranav, what is that paper, Pranav?
Kurt, this is a paper that describes the timing of IVH.
Yeah.
You were alluding to. So there's a link in there from JAMA Pediatrics.
Okay, well, I think I was talking about the same paper, but it's a summary from other papers, isn't it?
Correct.
Yeah, and when you look at the original papers, they didn't specify how often they look in most of them. So it's sort of a hard to make conclusion from that data, I thought. But we'll read it again. Yeah.
And we can also share in our WhatsApp group. So thanks, Koert, for sharing your expertise with us. Thanks, everyone, for their participation today and for rich discussion. I hope everyone found this session quite valuable. Have a great afternoon.
And thanks for sharing. So we'll be back next week with a Canadian speaker who talk about respiratory monitoring with absolutely amazing stuff, which I wasn't even aware is there. You highly recommend to see his talk next week. Hope to see you all. All right. Thank you.